Namaste Vidya, हमेशा खुश रहो Vidya. A very good morning to you all. Myself, Dr. Ravi Jain, Assistant Professor, Department of Practice of Medicine at Faculty of Homeopathic Science in JAYOTI VIDYAPEETH Women's University. Today we are going to start with another topic, that is Zollinger Ellison syndrome. This is an important topic from the examination point of view. You get a short note on this particular topic. In the previous lecture, we have discussed about peptic ulcer disease, and now in this lecture, we are going to discuss about Zollinger Ellison syndrome. So, what is Zollinger Ellison syndrome? We are going to discuss it today. It is a severe peptic ulcer diathesis that is secondary to gastric acid hypersecretion due to unregulated gastrin release from the non-beta cell endocrine. So what is it? It is basically a severe peptic ulcer diathesis. It occurs in the patients with severe peptic ulcer diathesis, and this is secondary to the gastric acid hypersecretion. That is due to unregulated gastrin release from non-beta cell endocrine. It is characterized by, so the Zollinger Ellison syndrome is characterized by a triad of three things: non-beta cell islet tumor, that is gastrinoma, gastric acid hypersecretion, and severe peptic ulcerations. So there is a triad of non-beta cell islet tumor, there is gastric acid hypersecretions, and severe peptic ulcerations. The three things are there. Okay. Now, what is the incidence of ZE syndrome? It occurs in 0.1 to 1% of the individuals that are presenting with peptic ulcer disease. The males are more commonly affected than females. The patients are most commonly affected are between the age of 30 years to 50 years of age. Now, what is the pathophysiology? The pathophysiology consists of hypergastrinemia originating from an autonomous neoplasm. So there is an autonomous neoplasm. The gastrin stimulates the acid secretion through gastrin receptors on the parietal cells. So there is gastrin stimulation, stimulates acid secretion through the gastrin receptors on the parietal cells. There is hypergastrinemia that leads to markedly increased gastric acid secretion through both the parietal cells. The increased gastric acid output leads to peptic ulcer diathesis, erosive esophagitis, and diarrhea. So there is hypergastrinemia that is leading to marked increase in the gastric acid secretion through both parietal cells. The increased gastric acid output that leads to peptic ulcer diathesis and erosive esophagitis and diarrhea. What are the clinical manifestations? The clinical manifestations of ZE syndrome consist of it is a gastric acid hypersecretion. There is gastric acid hypersecretion, so the great secretion of the acid. It is responsible for the signs and symptoms in the cases of ZE syndrome. So always remember ZE syndrome by hypersecretion of the acid. The peptic ulcer is most common. So due to the hypersecretion of acid, the peptic ulcers are most common, and at unusual sites such as post-bulbar duodenum, jejunum, or esophagus. There is diarrhea. That is next most common common manifestation. Manifestations. First one is the peptic ulcer. The second one is the diarrhea. That is most common, occurs independent of an ulcer. It is found in 50% of the patients. The diarrhea results from pancreatic enzyme inactivation by the acid and damage the intestinal epithelial surface by acid. So the intestinal epithelial surface is damaged by the acid. The epithelial damage can lead to a mild degree of maldigestion and malabsorption of the nutrients. So the damage of the intestinal epithelium surface by acid, epithelial damage can lead to mild degree of maldigestion and malabsorption of the nutrients. The gastrinomas can develop in presence of multiple endocrine neoplasia 1 syndrome. It involves three things: the parathyroid glands, the pancreas, and the pituitary gland. So parathyroid gland is involved in 80 to 90% of the cases, pancreas in 40 to 80% cases, and pituitary gland in 30 to 60% of the cases. Now, how will you diagnose the case of ZE syndrome? The diagnosis is done by biochemical measurements of gastrin and acid secretion. So biochemical measurement is the first thing. The second one is the serum gastrin levels that are grossly elevated. that is 10 to 1000 folds increase in the serum gastrin level. The H. pylori infection can cause hypergastrinemia. The gastrin provocation test is done. The tumor localization is best achieved by endoscopic ultrasound, EUS, by which the tumor localization can be done, and radio-labeled somatostatin receptors scintigraphy. The abdominal computed tomography scan, the magnetic resonance imaging, or the osteoscan to exclude the metastatic disease. This is that. Now, how will you manage the case of Zollinger syndrome? PPI means proton pump inhibitors are the treatment of choice. The PPI includes omeprazole, lansoprazole, rabeprazole, and esomeprazole. The 30% of the small and single tumors can be localized and resected. The synthetic somatostatin analog octreotide reduces gastrin secretion. Now, another topic is after the Zollinger Ellison syndrome, we have non-ulcer dyspepsia. This is also a very important topic because in this also we get a short note. So, non-ulcer dyspepsia means the chronic dyspepsia. This is a very small topic, but what it is, this is important because you find a lot of patients suffering from non-ulcer dyspepsia. So, chronic dyspepsia in absence of organic disease. So, that consists of non-ulcer dyspepsia. The symptoms include early satiety. So, the patient has early satiety. There is fullness, bloated, and nausea. Now, what is the pathophysiology involved? The cause is poorly understood, and it covers a spectrum of mucosal, motility, and psychiatric disorders. The incidence is usually it occurs in a young age, less than 40 years of age, and women are affected twice as compared to men. So the symptoms of non-ulcer dyspepsia were early satiety, fullness, bloating, and nausea, in absence of any organic disease. Now, what are the clinical features? There is abdominal pain. That is the most common feature of non-ulcer dyspepsia. It is associated with variable combinations of other dyspeptic symptoms. There is nausea, bloating after meals. There is pain or nausea on waking up. There is inappropriate tenderness on the abdominal by patient. The patient appears anxious and there is no weight loss. So there is anxiety of the patient, but there is no weight loss. Now, what are the various investigations that could be done in cases of non-ulcer dyspepsia? The most important thing is the history. The history will often suggest the diagnosis of the case, and the endoscopy is necessary to exclude mucosal disease. The ultrasound scan may detect gallstone. Now, management. How will you manage the case of non-ulcer dyspepsia? Explanation and reassurance. We have to explain the patient the clinical condition, what it is, and we have to reassure the patient. The fat restriction may help. Reduction of fat will help in relieving the symptoms of non-ulcer dyspepsia. Prokinetic drugs such as metoclopramide and domperidone are useful, and H. pylori eradication regime is controversial. In the next lecture, we will be talking about gastric carcinoma. So this was all about JV'n syndrome, Zollinger Ellison syndrome today, and non-ulcer dyspepsia. In the next lecture, we will be talking about gastric carcinoma. This session was powered by Digital version 2.0, JAYOTI VIDYAPEETH University. I hope you are satisfied with my digital session. If you have any query, please mention it in the comment box and I will try to resolve it. So this was all for today, and we will be meeting in the next lecture with a new topic.